We are live in 5, 4, 3, 2, 1. We are live now.
Good evening to all our viewers of OrthoTV. A warm welcome to you all. We are here with the 15th episode of our series on controversies and concessions in orthopedics, what we need to know. This series is being conducted bi-monthly every Wednesday evening with a new and hot topic in each subspecialty of orthopedics under the chairmanship of Dr. S.S. Mohanty and Secretary Dr. ASHISH PHADNIS, Dr. SWAPNIL, KENY, and myself, Dr. DEEPAK GAUTAM. Dr. Mohanty is the professor and unit head in the Department of Orthopaedics at St. George's Medical College and KM Hospital, Mumbai. He is also an honorary consultant at Jaslok, Nanavati, and Susrusa Hospital. He is the past president of Indian Orthoplasty Association and Bombay Orthopedic Society. He is a great academician and researcher. He is the education chair of Indian Society of Hip and Knee Surgeons, reviewer of famous journals like BJJ, CCO, and our own Indian Journal of Orthopedics. Today is the day of controversies in hip preservation, for which we have an eminent speaker, Dr. PRASAD GOURINENI, along with our moderators, Dr. CHASANAL RATHOD from Maharashtra and Dr. GYAN RANJAN from Bihar. I would now like to call upon Professor Mohanty sir to introduce our speaker and moderators and proceed with this session. Dr. Mohanty sir, all to you now.
Thank you, Deepak. Friends, greetings from Mumbai and welcome to yet another episode of Controversies and Consensus in Orthopedics. Friends, now this episode has been devoted to the hip preservation, which is a hot topic now, and in every meeting, in every conference that we are seeing, there is a session on hip preservation. And probably, the most invited faculty all over India is none other than Dr. B.R.K.V. PRASAD GOURINENI. And it's an honor and pleasure to invite him here, and he has been kind enough to be here to deliver the lecture today on hip preservation. Dr. GOURINENI is not unknown to Indian orthopods. He has done his master's in orthopedics from KMC Manipal, and he did his orthopedic surgery from Northwestern University of Chicago. He did his pediatric orthopedic from TSRH Dallas, and he's a diplomat of American Board of Orthopedic Surgery and a fellow of American Academy of Orthopedic Surgeons. He's at present associate professor of University of Illinois, Chicago, and he's at present chairman of Amar Hospital al Tirupati as well. Welcome, Dr. GOURINENI, and thank you for joining us today. Now, we have two eminent, moderators today, and I introduce Dr. CHASANAL RATHOD. Dr. CHASANAL is a pediatric orthopedic surgeon, Mumbai, affiliated to various hospitals in Mumbai, including the SRCC Children's Hospital, Hiranandani Hospital, Bhakti Vedanta Hospital, Mangalananda Hospital, and Xavier's Gate Lab. CHASANAL, could you mute yourself, please? And Xavier's Gate Lab in collaboration of Marquette University. His subspecialty is neuromuscular disorders, gait analysis, and pediatric upper extremity. He is the executive council member of our famous Bombay Orthopedic Society, and right now he is very much busy with our Western India Regional Orthopedic Conference, which is being organized at the Westin in Mumbai, and that is why we thank her for devoting some time to moderate this session. And she is the country representative for APOA, WAVES, Asia Pacific Orthopedic Surgeons, Women of APOA Advocacy, Education and Support. Thank you, CHASANAL, for joining today here along with us to moderate this session. We have another welcome. And we have another young orthopedic surgeon, Dr. GYAN RANJAN. Dr. GYAN RANJAN is an orthopedic surgeon from Bihar, and he has done his fellowship in spine surgery from Ganga Hospital, Coimbatore, and also from Indian Spinal Injury Center from New Delhi. He is a fellowship in orthoplasty in National University Hospital of Singapore and fellowship in spine surgery in Marian Hospital, Erwitt, Germany. He is recipient of Professor R.R. Ganguly Gold Medal Award for consecutively 2 years in 2021-2022 from Bihar Orthopedic Association Conference. Welcome Dr. GYAN today to this episode of Controversy and Consensus, and thank you for joining today. Now, dear friends, without any much ado, I hand over to Dr. Prasad to deliver his lecture, and then we'll have some discussions on this topic today. Thank you, and let me stop sharing my screen. I hand over to Prasad to share the screen, please.
Thank you, Dr. Mohanty. Welcome, everybody.
Hello.
I'll try to share my screen, and I'm going to turn my video off to save some bandwidth, but I'll be available to, you can stop me at any time to ask questions. Video off. What do I turn my video off? I thought I'll see my video off button somewhere here. Yeah, stop video. All right. Can you see my screen, Dr. Mohanty?
Yeah. Just to make it full screen, please.
Yes, I will. All good?
Yeah.
All right.
Fantastic. Thank you.
I'm going to minimize this. So my topic today is hip preservation, my favorite. But the title is When and How. Somewhat of a newer idea, but I put together a few slides. So hopefully you'll find it useful. So this is where I practice in Chicago, but right now I'm in India. I'm going to leave in 2 more days. It's in Chicago Christ Hospital, Level 1 Trauma Center and Pediatric Center. Here in Tirupati, right now I'm working in Amara Hospital. So my objectives today are to give you a brief history of hip preservation, define what modern hip preservation is, try to cover a few principles and cases that I have learned. We coined the term hip optimization. It's not normalization or just saving it, optimize the function. And a disclaimer, I'm going to talk more about my experience more than evidence. Suits well with the title of this series of Controversies and Consensus. So what's hip joint preservation? You all know that hip is a major ball and socket joint, inherently stable. The socket and head are quite stable through a wide range of motion and transmit almost 6 times body weight forces in certain activities. The standing itself is about 3 times, single leg stance. So hip preservation, in my opinion, is any treatment, surgical or non-surgical, to improve hip function while retaining the native femoral head. So you have to remove the femoral head for whatever reason. I'm not calling it hip preservation anymore. But if you can put the femoral native head in any biological acetabulum, we can still call it hip preservation. That covers the colonna type of arthroplasty. So history, the standard hip osteotomy that most people do, all of us do, is VDRO. But long before the VDROs, Albee has done histobuloplasty in 1915. I was surprised to see all this literature. Cam osteoplasty, 1903. I thought cam osteoplasty was new after my residency when I went to Bern, but 1903. Skeffy, the Heyman and Herndon osteoplasty, 1935. Perthes scalectomy has been there forever. Then capsular interpositional arthroplasty, 1901, or described first in 1901. Dunn osteotomy was in 1964, fish osteotomy in 1984. And you know the Salter triple and dial osteotomies are several decades old, or 30, 40 years old. So all these are part of hip preservation. So we've been doing hip preservation for a long time, though a few things have changed more recently. This man changed it all. On the left is Professor Reinhold Gans. When I visited him in 1998 in Switzerland, he was the head at that time. This is during a daily conference where he was showing X-rays and talking about pathology and morphology. So what did Gans accomplish? A lot more than I can list here, but there are a few highlights. The first thing I know that he really contributed is a periacetabular osteotomy. Still the most desired acetabular osteotomy that everyone wants to do for dysplasia. This was in 1988. Then, with this osteotomy was so powerful, he was overcovering a few femoral heads and found that about 5 of them came back with pain. That led to the concept of impingement from overcoverage in 1995. Then to understand what's happening in the hip, he developed a safe surgical dislocation approach. It's not a procedure, it's an approach to the hip, where you can dislocate a hip, look inside without risking causing a vascular necrosis. And then he was able to study the damage patterns and call it CAM, pincer, mixed type of impingement, and a whole lot of things came around after his SSD approach in 2001. Based on that approach, he's able to improve acetobuloplasties, femoral osteoplasties, and perform labral repairs safely. Then he went on to modify some older operation like modified Dunn, which is very popular. And I won't say it's popular, it's becoming less popular because people are having some trouble with it, but it's still a good operation. Modified colonna, the old colonna was improved with the SSD approach with GANs, modified colonna. Then he came up with newer procedures like reverse PAO. He was correcting protrusio by doing corrections with the PAO, exact opposite way as you do for dysplasia. Then he came up with relative neck lengthening, which is a very good procedure. And then he also came with head splitting osteotomies. You can split the head into two, take out the middle segments, and then put them back together and preserve the hip. Unthought of before him. So this is a famous photograph from his paper from 2001, where he showed that if you preserve these blood vessels, the medial circumflex ascending branch in the lateral epiphyseal vessels, the head can be preserved. With whatever surgery you do, if you preserve this vessel, you'll be able to save the head from getting a vascular necrosis. He also showed that this particular muscle, obturator externus muscle, if that's kept intact when it's attached to the piriformis fossa, this vessel is protected even when you dislocate the hip widely by about 6 to 8 centimeters. So that's where you can do a lot of hip preservation surgeries safely without causing AVN. Diagrams of SSD. It's a lateral incision in a lateral position. Straight lateral incision, Gibson approach, trochanteric osteotomy, a reverse Z-shaped capsulotomy to preserve the vessels in the top of the neck. Right? They're preserving the ascending branch, and here you're preserving the retinacular vessels, lateral epiphyseal vessels. Then you can dislocate. Even if you cut the ligament teres, no issues with blood supply. Right? You can widely dislocate, look inside the acetabulum, look all around the head and work all around the head and do a lot of procedures without worrying about AVN, causing AVN. Here's one of my cases. I'm just showing some extreme examples of what can be done. This is a child with the post-septic sequelae. One of two of such diagnoses I've seen in 30 years in America. It's very rare in America. I see almost 2 a week in India. But this is a post-septic sequelae. I thought it's Perthes, but when I went through the history, the head is too big. It was not fitting the acetabulum. This kid was having pain in the hip, right? So what we did was we surgically dislocated the hip, found that the acetabulum was itself healthy and nice and round, and the head was the problem. Then we split the head, took out a few millimeters in the center, put the two halves together. The head became smaller and rounder, and then started fitting the acetabulum better. Bigger head, smaller head that went deeper and reduced nicely. Same case, this is how you can do. After you dislocate, you protect the blood vessels, remove the central segment, you template it preoperatively on the X-ray to see how many millimeters you want to take. A socket, parallel sockets, or wedge cut, whatever cut you need to remove the undesirable part of the head. This head looks pretty healthy. This cartilage is also healthy, but the head itself is too big to fit into the acetabulum. So we removed about 4 or 5 millimeters of this bone in the middle, a segment like this. Put the two halves together and fix with some screws like this. And you can check viability of the head after the splitting and fixing together by watching active bleeding. And the head now fits the labrum and the socket quite well. This patient is about 5 to 6 years post-op and doing quite well. Then came the arthroscopists. Gans gave the concept of hip preservation, all the ideas of impingement and the procedures. Then arthroscopy took over. We are able to do a lot of procedures arthroscopically now, except with big osteotomies. You can do pretty much everything else intraarticular with arthroscopy, with 2 small incisions. You can evaluate the cartilage status with minimally invasive technique. Today, if I had to dislocate to look at the cartilage and put it back, it's a big operation just to look at how the cartilage is and if it's preservable or not. But one poke hole, look a scope inside, is a very good way to evaluate the cartilage status in borderline cases. And also allows dynamic evaluation. I can look at pretty much 0 to 90 degrees of flexion to see how the neck is interacting with the labrum, how the head bump is pushing on the labrum dynamically, much better than open procedure. When you're open, even when you do surgical dislocation approach with a big incision, once you flex 30, 40 degrees, you can't see anything in the front anymore. Everything closes up. But with arthroscopy, I can flex to 90 to 100 degrees sometimes and can see what happens between the head, neck, and labral mechanics. So this arthroscopy explosion came out with hundreds of studies, if not thousands now. And they come up with newer ideas like micro instability, FII-induced instability, and associated FII with the whole sort of things like sports hernias, muscle tears, strains, SI joint pain, back pain, a whole host of things. What we can see arthroscopically in distraction, you can see a lot through one poke hole and the second poke hole for an instrument to probe. This Spencer impingement in a patient, in a young person, a lot of damage already happening at a young age. This is an extreme example of actually doing a done osteotomy arthroscopically. I did only a few times and I don't advise it anymore, but showing you that it can be done. A moderate to severe slip, head is way back here on the neck. This family insisted that I do it minimally invasively. So we did neck shortening, removed a lot of callus, not callus, actual neck bone, reduced and fixed it. So arthroscopic done, it can be done, but not the best way to do it. Open is better through 2 small incisions. Now, the question, hip preservation. I was asked to do when and how, but I thought you should also spend one slide on why. Why do you need to preserve the hip? Total hips are great. The operation of the century, last century, is total hip. Great results, great service, 15, 20 years of very good function in 95%, 90 to 95% in older people. But you have to admit that native hip is more natural, more biological, has probably unlimited longevity if everything is working well after you preserve it. With THR, the issues still are longevity, wear, loosening, infection, dislocation, and the cost. And in younger people, the last time I checked, the bigger series is 15% failure at 10 years in people younger than 20. This, I think, is a Swedish registry, right? Most people claim that I can get 30 years on a total hip right now, but none of you have done hips for that long in younger people to really claim that at this time, right? So I think that it's worthwhile preserving a hip if you can avoid one revision in a patient's lifetime, in a younger person, right? 10, 15 years, one revision. I think it's worthwhile trying to do a preservation surgery, open preservation surgery. And my threshold is even less if it's arthroscopic. So if the risk-benefit analysis favors HP in that hip in your setting, not in Ganja's hands, not in some expert's hands, in your setting, in your hands, if hip preservation has the cost-benefit analysis in favor compared to a total hip, you should try to preserve that hip. Keep in mind that improvement can take up to 6 months, especially in Indian patients. They take longer to really get the benefit of hip preservation surgery. So don't be impatient and think that it's a failure. Somebody's limping and having pain at 3 to 4 months after your surgery. When not to do it. Several papers have said 2 millimeters predicts poor results. So if the joint space is less than 2 millimeters, that's too much damage and results are not as good. People have said Tony's grade 2 arthritis, where there's clear loss and some cyst formation and things like that, predicts early total hip conversion. So if you have advanced arthritis, preservation may not do very well. And keep in mind that house cleaning procedures of removing osteophytes and loose parties and synovectomies don't do very well in hip arthritis. So don't do it if there's arthritis. Now, how to do it? I'm going to spend the rest of the talk on how I do it. Hopefully, I'll impress on you that it's a decent approach. I've been doing it almost for 30 years now. So make the diagnosis, right? Easy said than done. Find all potential causes. Cover all bases. Just see what all can be causing the hip pain. Then you consider all the treatment options, right? Broad. And then you figure out if you want to address the most likely cause with a minimally invasive approach or treat all potential causes. Like we did in SSD, there's no good reason not to address all potential causes, because you can do all of them without too much more morbidity or too much more time. Hopefully I can impress on that a little bit more with case examples. So you all know that primary OA is rare. It's almost always secondary OA, right? The obvious causes of secondary OA are infection, inflammation, trauma, AVN, tumor, things like that, well established, right? You know about all those. Then it's called mechanical hip pain. When you have pain, not from any of these primary causes, but from morphological variation, change in the shape, size, tilt, orientation of the bones, or the proximal femur or the acetabulum, then you call it mechanical abnormalities. All these causes can don't think the primary
I think some network issues.
Yeah, some network issue. The voice was also breaking before it.
Yeah. Now he has joined though.
Can you guys hear me?
Yes,
Yeah.
Where did you lose me? At what point?
primary OA is rare.
Okay, I'm going to go back. I'm sorry. Looks like something happened in the connection.
Yes.
Yeah. No issues, please.
All right. So primary OA is rare. All good now?
Yeah.
All right. Sorry. So once you rule out things like infection, inflammation, trauma, AVN, and tumor, the well-known hip problems, then becomes mechanical hip pain, which is pain caused by morphological variations, shape, size, and alignment of the bones causing problems. For example, incongruity between the head and the acetabulum can cause pain. Acetabular can cause pain. Coxa valga causes instability, like you put valgum or fovea alta. Anteversion of the acetabulum and femur can cause anterior instability. So these are morphological variation that can cause instability of the hip. Then things like protrusio or retroverted acetabulum or retroverted femur, coxa vera, or a spherical femoral head from whatever deformity can cause impingement type of problems. So these are under mechanical causes where there's no primary disease like infection, inflammation, or Cortis or Skefi as a main cause, but the residual morphological problems caused by these diseases or primarily by unknown idiopathic deformities. We call it mechanical hip pain. One point to make is labral tear is not a diagnosis. Labral tear is just a finding. Almost all painful hips from mechanical causes will have some labral damage and some labral tear. So labral tear should not be a diagnosis, and labral tear repair itself is not a treatment. You need to find out the cause and fix that cause more importantly than repairing the labrum. And keep in mind that most hip pain is pre-arthritic. If you don't treat the hip pain, it's most likely to lead to arthritis at some point. So 3 questions. The way I try to diagnose a mechanical hip problems are, one is the pain coming from the hip joint itself? A lot of people, especially younger people, complain of knee pain when the hip is a problem. So you say, when they complain of knee pain, you need to check the hip. You check the back to see if any back problems are causing hip pain. Pelvic problems, ovarian problems, hernias can cause hip pain. So you need to rule those out, right, first, and say, okay, it's hip, whether it's hip problem or not. Once it's a hip problem, is it mechanical or non-mechanical? Did you rule out primary diseases like AVN, bone marrow edema syndrome, tumors, infections, rheumatoid arthritis, ankylosing spondylitis, things like that? Once you're happy, say MRI is normal, all these are gone, all non-mechanical causes are gone. Then you say it's mechanical hip pain. Then you start looking at what are the potential mechanical causes? Which one? Is it the varus I see? Is it the protrusio I see? Which one is causing the problem before you try to fix it? So we'll try to discuss how I go about doing this. So you have these tools available to diagnose for the hip. History usually generates a differential diagnosis. As you're talking to the patient, you can say, you can make a list of things that you need to rule out, right? If they say chronic pain for a long time, you still think tumor and infection, but something started having pain recently, a day or two ago, you're less likely to think about tumors and infection. You're more likely to think about injuries and strains and sprains. Physical exam, keep in mind that you have to get up and examine the patient for the hip. FII is purely clinical. FII is a clinical diagnosis. Nothing radiographic can make the diagnosis for you. It's corroboratory after you make the clinical diagnosis to figure out what's causing the FII, but FII is a clinical diagnosis. Plain X-rays are quite adequate to look at the morphology. CT scan can show CAM better, tell you exactly where the CAM problem is, how bad the CAM is. Not essential, but a good tool. MRI, I get it mostly to rule out non-mechanical causes. If the MRI is normal, I'm pretty comfortable that I'm not missing any tumors, infections, AVN, bone marrow edema syndrome, and things like that. And MRI may show a labral tear that supports your clinical diagnosis, but it's not essential to have a labral tear to diagnose FAI. Then injections, selectively, when you cannot localize the source of pain, somebody comes with knee pain and you can't say if it's coming from the hip or not, numb their hip up with some lidocaine, and if the knee pain goes away, you're more comfortable calling it a hip-originated knee pain. Then lastly, it's important that you keep your mind open, even when you're doing an exam under anesthesia, still keep your mind open to look for things so that you can confirm your diagnosis or rule out other problems. Exam under anesthesia, even intraoperatively, if I did a arthroscopy or SSD, I'm still dynamically evaluating and changing my plan, because these things are important to not miss something important and not do a wrong operation. Classic impingement testing, flexion, adduction, internal rotation. Here's a anterior apprehension test, extension, adduction, and external rotation. There are about 7 or 8 more tests that can be completed within about 2 or 3 minutes of good exam physically to figure out a lot of hip problems. Then you have plain X-ray. The most important plain X-ray is AP pelvis. AP pelvis gives a lot of information. In addition to your ilioischial line, pectineal line and all that, and the teardrop, you can see the sourcil to know the size and width and the tilt. You can see the relationship of the weight-bearing axis to the sourcil, almost perpendicular is ideal. You see the anterior wall, you see the posterior wall. So you have all parameters established, seen very well on AP pelvis. If you get a AP hip X-ray, you don't know how this establishment is oriented on the pelvis, and you may overread or underread coverage. So it's important to have a full AP pelvis that's sort of perfect, or you adjust it in your head to make it perfect. Same X-ray. LCE, lateral central junction for dysplasia, about 25 to about 40 is normal, more than 40 is too much, less than 24 is dysplasia. Also start looking at medial coverage. People don't talk about it, but even MCE should be at least 20 degrees. So if less than 20 is medial dysplasia, more is not a problem medially. Another way to look at sourcial angle, 0 to 10 upsloping is ideal. More than 13 is dysplasia, and less than 0 is negative sourcial angle, a risk for impingement and medial loading. The sourcial should be well below the fovea should be well below the sourcial, so the ligament of teres is not being compressed. So this area should not see any load against the acetabular fossa or against the sourcial. So fovea should be nice and low. Here's how you look at sphericity of the femoral head on X-ray. A lateral view. Draw this longitudinal axis of the neck. That's a line from the center of the head to the point at which the head is becoming spherical. We call it alpha point. So this is where the alpha angle comes into play. And this angle, ideally, about 45 is good. More than 50 is cam morphology. And here you can see it's almost close to 80 degrees. So significant cam morphology with no concavity of the neck. right? That's cam morphology, not cam impingement, cam morphology. Like I said, CT scan shows this cam better than X-rays, but you can interpret X-rays quite well if you train your eyes. But till then, you can get a CT scan. This is the cam before and cam post-op. MRI is excellent to look at soft tissues. A labral tear, like I said, you can see it in MRI sometimes, but not important to have it or not have it. It's more to rule out other pathology. So with that background, now we're going to go back to this mechanical or morphological hip disease. So when do you call it mechanical? When the pain and arthritis are caused by morphological variations in the hip and not from any primary disease process. Keep in mind that asymptomatic morphological variations are very, very common. Half of us will have some variation from ideal. So ideal is not always normal, but usually if it's asymptomatic, it's probably a normal variant. Bombelli said a long time ago that to have pain and arthritis, you need to have morphological variations, activity level to cause wear and tear, and then biological response of the body, biological predisposition. Not everybody with cam morphology and activity levels will get arthritis at a young age. Some people take much longer. I've seen 50-year-olds with very little damage, and 15-year-olds with damage already from similar or lesser cam morphology. So we need to figure out how to determine the clinical significance of these morphological variations, because you're going to see these variations all the time. Once you know how to read X-rays, you see variations all the time, but you need to figure out which ones are clinically significant. So let's list the morphological causes under these 4 headings. Focal cartilage defects, OCD, that fovea being high, loose fragments in the joint from trauma or whatever reason, step-offs in the joint articular surface, gaps in the articular surface. These are all cartilage problems focally. These can cause pain. Instability of the head, stellar dysplasia, coxa valga, increased anteversion can cause dysplasia or instability of the head, causing pain. Impingement, coxa vera, breva, plana, profunda, prominent AIS, prominent GT, prominent LT, all these can potentially cause impingement, right? And then abductor dysfunction, your coxa vera, coxa breva, cause liver arm problems. And then too much version, anteversion or retroversion can also cause abductor dysfunction. So I'm able to group almost all potential morphological cause into these 4 categories. Then under these categories, your treatment options are for cartilage defects. You can either repair the defect, graft it, or reorient it so that it's not in the weight-bearing area anymore. For instability, you can make it more stable by reorienting the bones that are disoriented, or deepen the socket on the established side. And the instabilities from head being too large, you can reduce the head size. Or enlarge the acetabulum like with the Chiari. Impingement, you can make the head round if it's not spherical. And you can increase clearance for all of the bones that are impinging. Abductors, you can adjust the liver arm, resting length, separately or together. Or you can repair the abductors if they're torn. And you can even do muscle transfers if the abductors are irreversibly damaged, like gluteus maximus transfer for gluteus medius palsy. List of procedures. You do some of these already. The femoral side, starting from shaft and trochanteric osteotomies, derotations, varus valgus. Intertrochanteric, again, varus valgus. Or flexion extension. We did one early today where I had to extend the osteotomy about 60-70 degrees to get good orientation of the head in the acetabulum. Base of the neck osteotomies, you can go more proximal and do subcapital or transcervical osteotomies safely. You can lengthen the neck, shorten the neck. You can do chilectomy or cam osteoplasty. Then I showed you example of head reduction osteotomy, or you can do bone and cartilage grafting of the head or the acetabulum or the head on the femoral side. On the established side, you can graft established defects, allograft or cartilage from somewhere else. You can reduce the rim if it's too deep, overcovered. You can resect established rim and make it shallow. You can redirect the acetabulum, Salter, triple, or PAO. You can reshape the acetabulum by Pemberton's and Degas. You can enlarge the surface by doing shelf or Chiari, or you can create an acetabulum that's not there, ream it up with a tortillary reamer, and put a capsule in it, and put the head back in called capsular arthroplasty. The dilemma is variations are common. which variation to treat and how much, and how to check for functional significance of each variation. And basis, how to check hip function. Can you have a pre-op plan saying that I'm going to do 30-degree varus? Will that be ideal when you find something intraoperatively? Are you ready to change during a procedure to optimize the hip? So when you look for function of the hip, is it pain-free and limp-free? Is it a particular range of motion in a particular direction or all directions? Is it the ability to sit, stand, squat in Indian situation, run, jump? How long and how far? If somebody has to analyze a good function. And how are you going to figure out all this intraoperatively if you restored everything or not? Are you going to base it on neck shaft angle, LCE, or alpha angle, and how much is ideal, right? Are you going to go to normalize all these things, or you have a way to assess function intraoperatively and on your preoperative plan? So this led us to come up with these 4 pillars for good function, or 4 elements of good hip function. Am I still good?
All good, all good. Please
Thank you.
carry
Okay.
on. Yeah.
So the 4 pillars. So remember how we grouped all the causes into 4? There's 4 things, we're calling them pillars now, or 4 functional elements. So if you restore these 4 pillars, you can pretty much assure that somebody's going to have good hip function, because you can't check all hip function intraoperatively or in your preoperative plan. So if you have healthy cartilage in the weight-bearing area, that hip is going to be pain-free and probably will do well. In addition, the head should be stable in the socket. No lateral or medial instability. It should line up nicely with the sourceo and not have any medial or lateral subluxatory risk of the head. And you can check that intra. Impingement-free motion. The movement range, you can check intraoperatively in all directions. And you should provide enough motion without leaving the femoral head aspherical. An aspherical femoral head, even with good motion, can cause pain. So you want the head round and then have good range of motion in all directions. Good range of motion adequate for that particular patient based on your assessment of what their needs are. Somebody is 50 years old and has not a sportsman, and all he has pain in the hip. You don't need a lot of motion. You don't need to give him extra flexibility. You just need to remove the spherical part and stop the hip from impinging and give good muscle function, especially the abductors. So how to use these 4 pillars? Preoperatively, you can identify clinically significant variation. I'm going to give some examples to explain that. And you also can predict consequence of your treatment plan. So you plan something and you say, okay, I'm going to do valgus osteotomy. I'm going to show an example anyway. I'm going to wait for the next slide. All right. Intraoperatively, you can look at the cartilage status. Say if you see a defect in the weight-bearing dome, you can start change your plan. That's exactly what we did today. We went to the idea that we'll do 30-40 degrees of valgus. That's all we thought we'll do. Once you saw the cartilage is more healthier anteriorly. So we decided to extend at the osteotomy to rotate the anterior part more superiorly. So intraoperatively, based on the cartilage status, I adjusted it so that I'll have good results. If I didn't open the capsule and did not know what the capsular status is, would not be able to optimize that cartilage surface. And dynamically evaluate during surgery. Keep on checking to see if the hip is stable and if the hip is not impinging in different directions. Here's the example I'm talking about. Say example, somebody came with a neck shaft angle of 100 degrees. We measured 100 degrees on a neck shaft angle in X-ray. Very abnormal, right? But if that neck shaft angle is not causing any problems in that patient, no symptoms, good motion, everything is good, no treatment. Who cares if it's 100 degrees? You're going to leave it. But if it's preventing lateral subluxation in somebody with dysplastic, slightly established dysplasia, there's a neck shaft angle 100 degrees, they're compensating with each other, do not correct the valgus, correct the varus into valgus, because you're going to unmask that hip established dysplasia and cause the hip unstable. So it tells you if there's varus and stable head, you probably should not do any valgus and destabilize that hip. If there's medial subluxation, which is very rare, but the head can be migrating. It's not as rare as you think. We just don't hear it as often. But the head is migrating medially onto the acetabular fossa and not in direct contact with the sourcil anymore. In severe varus, you can see that. In that particular case, the head is rubbing against the non-articular portion of the acetabular fossa and can cause wear and tear medially. In that situation, you know that you have to do valgus to bring the head out from the medial side. So you're not going to do any other option other than valgus, or sometimes a PIO to make the hip unstable so that the head can migrate laterally. If the NSA of 100 degrees, no instability, no cartilage problem, but it's causing impingement, decreased range of motion, then you have to think about impingement treatment. Can be valgus or relative neck lengthening. Right? Relative neck lengthening does not change the head establer and shaft alignment, but only moves the top part of the neck away so that you won't impinge anymore. If all you have is abductor weakness from this 100 degrees, you just have to do either a valgus, a GT transfer, isolated GT transfer, or a relative neck lengthening. It's a comprehensive GT transfer. So the whole idea, which all of us want to do, is avoid over or under treatment. So if somebody says that I'm going to restore all parameters to normal, neck shaft angle 127, I'm going to get this alpha angle to 45 and establish index to this and that, you'll be doing a lot of surgery unnecessarily, over treatment. And also, are you capable of restoring all parameters to normal? Are you good to assess them and make them normal? Maybe not, right? You can't restore every parameter and make everything perfect, and it'll be too much surgery if you can. Some people say, I'm going to match it to the opposite side. I'm going to make it exactly look like the opposite side. Who told you that the opposite side is normal, number one? Who said that the opposite side, the parameters are all well known and can be understood and can be replicated? Just doing a neck shaft angle equal to the opposite side will not be making the hip equal to the opposite side. On the other hand, if you say, well, there's coxa vera and there are other problems, but I'm going to treat the varus just with valgus osteotomy, just one thing, you may be under-treating and may have to repeat another operation or more than one operation to treat each cause. So to avoid over under treatment, again, you can apply these 4 pillars. So let me go back to the little anatomy here, right? There are 3 options for me when I do hip preservation surgery. A straight anterior approach, Smith-Peterson, Hutter, whatever you want to call it. It's very good for anterior work. Anterior labrum, anterior rim, anterior cam is reasonable. Not as good as arthroscopy in my hands, but can be done very well if you're experienced with it. And all established osteotomies can be done. Salters, Pembertons, PIO, everything can be done through this approach. But you cannot go to the back of the hip. You can't really safely dislocate the hips. I've seen some people dislocate it in this approach, but I feel uncomfortable doing it, so I don't dislocate it. I can look inside the joint very well. Some people use mirrors and scopes, but can be done, but not ideal. Arthroscopy, most intraarticular work, pretty much everything intraarticular that Smith-Peterson can do, I can do arthroscopically. I can even get to the AIS and lesser trochanter with endoscopy, but cannot do any major extraarticular osteotomies. SSD approach, I can't think of any procedure on the femur or the acetabulum that I have not or cannot do with SSD, right? SSD is such a uniform, not uniform, but comprehensive approach that you can pretty much do everything that I've listed earlier. So here's a case example, a few case examples to tell the points. Here's a right-sided severe slip, very severe slip. You can see the head is in the back of the neck completely, right? Can't go any further. But more importantly, the neck is digging into the acetabular rim, right? So doing inside screws and little osteoplasty is not going to do anything to this patient. You need an osteotomy. When this deformity is so severe, distal osteotomies have to produce so much deformity to correct this. So the correct operation for this, if you have the technique, if you have the experience to do this, is a subcapital osteotomy. Somewhat controversial, the statement. A lot of people are shying away from doing these osteotomies because they're having more and more complications. But I confidently tell you that if you learn it correctly, it's a good operation, right? You can restore near normal anatomy without causing AVN. Here's another slip. Here you can see how the right side, severe coxa valga and subluxation. So this hip was probably like that. We had a suspicion that even I get the slip corrected completely with a done osteotomy like this, that I may get into trouble, and the hip was unstable. So I had to do varus in addition to it. So slip correction, pinning, and then varus to stabilize the hip. The 4 pillars again, no impingement, no instability, good abductor function, and good cartilage on top, right? Then you can assure yourself that this hip is going to do well afterwards. Here's a Perthes deformity in a 16-year-old female. Multiple problems. The cartilage looks healthy. If there's no good cartilage, you can't preserve a hip. If you can't restore cartilage, you can't preserve a hip. So there's good cartilage, can be preserved. Head is not very spherical, has some sagging rope signs, but not a very big cam deformity. Coxa breva, very high trochanter, impinging in all directions. Historal dysplasia, very severe. Posterior wall is only covering 20% of the head, crossover sign. So if you open this hip capsulotomy, this hip will dislocate. It's relying on its capsule to stay in place. So either you do not do anything intraarticular or stabilize this hip for sure. And to do a PIO to stabilize this, the trochanter will be in the way. So you need to do multiple things, right? Again, 4 pillars. Cartilage itself is good, so I don't need to do anything with the cartilage. But I need abductor lever arm and GT should be cleared, right? No other impingement. Then I need to stabilize it. So here's what we did. First is relative neck lengthening. No cut between the head, neck, and shaft. Just move the trochanter down and remove the top part of the neck to create a longer looking neck. Functionally works well. So you don't need to really do motions and all. Relative neck lengthening is good enough to give you good neck length. The head orientation to the shaft is quite good. And even the acetabulum is quite good. So all we did was rotate the acetabulum on top, RNL and a PIO, right? So you want to do least intervention to optimize the head. It's not just doing a lot of surgery, but do the least to get the best result. Here's a case of a younger child, not that old, probably more like 10, 12, dislocated hip. No real acetabulum to really reduce and put in, no socket. Here's the thing I'm talking about. You have this capsule, redundant, stretched out, untouched, right? Untreated dislocation. So you take advantage of that. What you do is you remount a bony socket with a total hip reamer, right? Create a socket. If necessary, put a shelf on top of it if needed. When you do femoral shortening, bring the bone on top. Cover the head with this capsule and put this into the socket, like that. That capsule becomes the articular cartilage and can last up to 20 to 30 years. In about 30% of hips with older techniques, colonias have lasted more than 30 years, right? So it's not a bad operation. And I've done about 6 or 7 so far. Not a lot, but I'm happy with it. Here's an example of protrusio, really overcovered. Well, I can't call it protrusio, but very, very overcovered. Protrusio is head crossing the ilioischial line. Here it's not crossing, so it's not protrusio, but profunda, very deep, impinging. So I measured that I can remove 15 millimeters of the rim and still not make it unstable, because I don't want to make it unstable. I need 4 pillars. I need impingement free without causing instability. So my pre-op plan included 15 millimeters of rim trimming. And that's what we did. We removed all this bone arthroscopically and relieved the impingement. Last example, a girl with crossover sign, anterior coverage, posterior deficiency. So truly retroverted acetabulum causing anterior impingement. If I remove the rim in the front, the posterior dysplasia will be untreated. And once I remove the rim, I cannot rotate it back to the PIO. So the primary treatment for this was anti-verting PIO, where the posterior wall increased and the anterior coverage decreased to correct the impingement. So finally, we call it hip optimization, not just preservation. The goal is to restore all 4 elements of hip function. When you leave the operating room, you want to leave after restoring all 4 elements. But keep in mind that arthritis in all these hips is inevitable. I may get 30 years, even 40 years, but the people I'm operating on are 15, 20 years old, and they're going to live to 60 and 70. They're going to get arthritis. So some of you arthroplasty surgeons, we're not going to take away your practice. You will still have plenty of hips to do. And my job is to not create deformities that make future reconstruction difficult. So hip optimization should be restore hip function well, but don't make a hip replacement difficult afterwards. Thank you very much.
Thank you. Thank you so much, Dr. Prasad. That was an excellent lecture, really. It was an eye-opener for me, at least personally, and I'm sure for all the viewers who are attending today and who will be viewing your lecture in future also. They will be amazed by this lecture. And it was an excellent postgraduate lecture also. I think I had told on my postgraduates to join today, and hip preservation is really growing up very nicely. Before I hand over to Dr. CHASANAL and Dr. GYAN, I have just one question. How often you see the patients of idiopathic chondrolysis in the United States as well as in India, and what is your approach to this condition, preserving the hip?
Great question. It's less common in the US than in India. In the US, I probably see maybe once in 2 years.
Yeah.
And I have a few that happen post-operatively after my surgery also. And they're particularly common in certain racial, like American blacks seem to have a little more preponderance in America. And female patients. And what is, most of them have some risk factor for impingement, like protrusio or overcoverage, some type of deformity in the hip. And in India, it's a little more common. I see probably 2 or 3 a year of chondrolysis. And again, there is, I don't have gender or profiling in India yet, but I can tell you that it's more common in India than in America. My approach, I believe it's more opinion. It's my opinion, basically. I think it's some focal autoimmune phenomenon happening in the hip joint itself. Something triggers the damage, a screw into the joint, a little impingement damage, something triggers the cartilage damage, and the joint gets destroyed really fast in a generalized fashion. And what I've noticed is, if I give it time and treat them symptomatically, just do some physical therapy, just wait it out, in a year or two, most of them get back the joint space. So my treatment has been observation, encouraging them not to do anything aggressive, no injections, no medications as much. If the contracture is severe, I don't mind releasing the contracture to improve their function so that they can walk more straighter. But otherwise, I just wait it out. And I believe it's close to 80-90% where the joint is improving, almost normal, but with some residual ring osteophytes that grow around the head and neck. Some I have released, I've removed them, but I'm hesitant to see if I'm going to trigger a second autoimmune phenomenon in them. So I caution them. And so I'm not as aggressive in treating that residual impingement, but chondrolysis, in my opinion, improves spontaneously if you wait long enough.
Okay, thank you. Now I hand over to Dr. CHASANAL and Dr. GYAN also. Yeah.
Thank you, Prasad. So it's always great to hear you. So continuing with the chondrolysis, which Mohanty sir just asked you. So when would you suggest the role of chondrodiastasis or an external fixator would be needed? Or which hips we would be anticipating that they could become stiff hips? So like, is there a way we could avoid or just like wait and watch, you said, for spontaneous healing or resolving the symptoms?
Yeah, just to emphasize again, chondrolysis is an enigma to me. I don't know what causes it. I don't know who gets it. I don't know how they're going to improve or not improve afterwards. So totally unknown. At the same time, I have not done any distractions. I have not used any medications. All I did was wait, and the contraction and stiffness was so severe, they're not able to even walk properly because they're flexed and abducted so much. I released the capsule, contracture releases. That's all I have done. The only patient in my experience that had not improved was a girl who did not like my approach. She thought I caused the chondrolysis after my hip arthroscopy. So she went on to different doctors and got steroid injections, played basketball, had procedures. And in a year or two, she couldn't wait long enough, had a hip replacement in America. Other than that, if patients listen to me, I wait it out, little contracture release, and pretty much everyone improved in my experience. Maybe they didn't follow up with me any further and went somewhere else. I can't tell you that all 90% have improved, everybody improved. But my general experience is they do well. So all the other measures of people being aggressive with different medications and surgical procedures, I don't think the results are any better than observing. So somebody has to do a study to really see this. But my colleagues, we are about 7 orthopaedics in my department right now here. And all of them agree. You can ask them privately to see if their observations are any different than mine for chondrolysis. None of them are doing anything aggressive, and we're happy with the recovery.
Dr. GYAN?
Thank you.
Hi. Thank you so much. It was really informative talk. And I want to know, sir, how many cases till now you have done, sir? And have you operated any here?
Which one? Sorry, tell me again. Which procedure?
Come on, sir. You are resecting the head and then you are fixing it with the screw. Have you done it here in Tirupati?
You're talking about head reduction osteotomy?
Yes.
Oh yeah, head reduction osteotomy. I'm not doing a series, but I've probably done about 25 to 30 at least.
In Tirupati?
No. In my experience, my whole life. And
So, sir,
Tirupati, we have done in Tirupati without any hesitation. We have done one last week.
okay. So, sir, what is the longest duration you have follow-up for that?
My follow-up longest probably is 8 or 9 years that followed with me. But I've been doing it since 205. So probably I have patients that have operated on 15, 20 years ago, but they have not been coming back to me. But people who have come back to me that I followed for whatever reason, 8, 9 years. But the report, the literature is at 10 years, right? At 10 years, no conversions in the burn group. And I'm not aware of any conversions. I had complications for sure. I had 2 instabilities after head reduction osteotomies because I was not stabilizing the hip concomitantly, and the hips subluxated afterwards. But AVN and cartilage damage or arthritis, I'm not aware of any yet.
Yeah. So the patients are not coming back in. At my place of practice, I think they have really been benefited with the treatment. That's why they are not coming.
Yeah, they're always possible. Also, I'm not following them as closely, but literature also. And you'll hear from somebody, right? If somebody's got converted. I know that 2 didn't do well. They start dislocating. The obese patients, I did head reduction and I did not do a pelvic osteotomy. And the patients subluxated, dislocated. So that's not a good result.
Anyway, so thank you so much for your work.
So how high is the stiffness post this head reduction osteotomy, sir? Do you experience that initially for certain times this hips are stiff and later they do well? Is it so, or like how is it in your experience?
Head reduction does not have a particular complication of hip stiffness. The more concern is instability. Instability, screw loosening. I haven't had any non-union, but I had, like I said, 2 instabilities I know of very well. Now I add a stable procedure even when the stable looks pretty good. Stiffness is not particularly a problem, but abductor weakness can be there for almost 6 months to 9 months because you're changing a lot of things in the hip. So trochanteric transfers can take a while to heal and restore the abductor function. So lymph can be there for a while. But again, people have seen, I've resolved. I didn't have to go back and do any, I have non-unions of trochanters. When they don't heal and they are symptomatic, I've gone to repair them. But nothing like a permanent damage.
So one question.
Yes.
This hip preservation is something very much fascinating for me. I like these lectures being, spoken, but though many of the surgeons want to go for other procedures rather than being hip preservation first, it may be true that they all are not that much experienced to do the hip preservation surgery because of the lack of expertise. Second, nowadays everyone thinks that okay, down the line they are obviously going to have a replaced hip, so let us keep it as likely something. In your practice, in which condition do you accept other than idiopathic chondrolysis, that just like you said, in which are the conditions where you want to leave as it is? Okay, this patient is going to have a replaced hip in the future, and these are not to touch. Any specific indication? One. Second, sir, whenever you are doing this such type of osteotomies, many people say that you need a translucent table and special osteotomes while performing this surgery. I know you, for an expert like you may not require those all instruments and specialized. For the beginners to start with, is the translucent table mandatory for all those procedures?
To do a PIO and supine position, if you don't see things well and you're not as good as GAN, you're not GANs, then you need fluoro. So it's important to be able to see the pelvis really well in AP and 45-degree obliques. And you know that most of the pelvic surgeons do have that facility and they're doing it. It's not something unavailable in India. Now, if you're doing an SSD on the lateral position, the table is not important anymore. The C-arm can be rotated around, and you can get AP and lateral with the C-arm in the same position by moving the hip around. So you're not relying as much on fluoro or the table when you're doing SSD, surgical dislocation approach. Your first question about which hips should be left alone. There is this controversy. It all depends on your indications, right? There are no absolute indication and contraindications. It all depends on you and the patient. I don't talk anybody into having surgery because I'm not saving their life. I'm not sure if I can save their hip. I may be able to save the hip maybe 5 years, 10 years. It's hard to predict. So I give them about 10% of my patients come back for surgery. I don't give any guarantees. I don't give any of that, right? I tell them that you can wait for a hip replacement or you can try this. So, and also, I know that almost all my patients will get a hip replacement ultimately. At what point is the question? Are they going to get it when they're 15 or 20? Or are they going to get it when they're 40, 50, or 60? And like I said, if I can get them 10 years of good function, I can save them maybe one revision in a younger person. I think it's worthwhile. But again, you have to look at your situation and you decide if the risks are the same in your hands and not rely on Ganja's experience or what we do in Tirupati or what somebody else does it somewhere else, right? And more importantly, keep in mind that none of these are difficult surgeries. I mean, I'm not a great surgeon. I'm just an average surgeon. I just took interest and I learned. So don't rush into them. Go step by step. You all do hip preservation already. Almost all of you do some videos and some sternoplasties already. So it's not like hip preservation is all or none. You slowly grow in, find your comfort level, learn. Some things are tricky, but SSD is something you can learn very easily. Understand the technique, look at some videos, maybe see one procedure being done by somebody, know the blood supply, and you can do an SSD. It's just an approach, right? Once you do SSD, how incrementally increase to the difficulty of surgeries depends on how fast you can learn and how make it safe. Don't take risk with your patient. Call somebody, take your patient. For me, I tell people that if you want to learn, just come with your patient. Bring them to us. When I operate, you can scrub and watch. And we do courses. We talk about it. We discuss on the groups all the time. I discuss complication more than my good results. I just showed you today what can be done, how and when. If Dr. Mohanty gives me time, I can tell you all the complications that I've seen and how to avoid them. I know also how to avoid them because I've seen them, right? If you look at the Swiss literature, you won't see complications and you won't see how they figured that out, right? But every complication I mentioned to them, they have a solution for it, right? So I'll be happy to, and also all my publications, I don't talk about my good series. Whatever I published, usually it's either a technique or it's complications. I'm hoping that you learn and you don't learn from your mistakes, but learn from mine so that you can start off at a better place.
Correct. GYAN, you have a question?
Yes, sir. So, what would you prefer, core decompression or osteotomy?
Sorry, GYAN, for some reason I couldn't get the words.
So, what I was asking you, what would you prefer?
Yeah.
Have you done core decompression or osteotomy? Which one?
Oh, for AVN.
Yeah.
So I have very strong feelings about AVN. Just to give my opinion, right? AVN, the head, in my opinion, the head collapses only when the osteoclast makes some holes in the head. I don't believe that it's a dead head getting stress fracture accumulation and breaking. There's another theory. I don't believe that's true. I think it's the osteoclast, the blood supply going back and making some holes in the subchondral area. When the blasts are not keeping up, you get weakness and you collapse. So my goal is to prevent collapse. And I've done core decompression. It's great to decrease pain when the pressure is high, but I don't think it'll really improve the mechanics of the head in terms of improving blasts and decreasing class. So actually, I use bisphosphonates a lot. I use bisphosphonate orally, but the problem with oral is, when is it going to go to the head? When is the head going to revascularize? You're giving all this medication for a year, and if that it not revascularize in that year, all that medication is a waste. We don't have the right dose at the right time and the head is revascularizing, it'll be a waste. So I've been offering injecting the bisphosphonate into the head directly.
Oh,
right? Instead of core decompression, we put a tight needle, no tracks, just put a Jamshidi needle into the AVN part of the head, on top of the head, inject slowly, about a 3 ml mixture of zolutonic acid solution. And that seems to work really well for us. We're looking at our results. We're probably close to 90% success, regardless of the size of the lesion. Obviously, anybody who says 90 and 100, don't believe them, right? We're lying. There'll be failures for sure. But this is as good as any other complex procedure people are doing. People are doing stem cells, bone marrow aspirates and all that. These are 1,500, 2,000 rupee vial, off the shelf, sterile, that I'm injecting. And my colleagues, again, ask any of them, call them privately. There are 6 of them in my group that do these injections routinely. We're still continuing to do them because our results are good. We didn't switch because we're happy with what we're doing.
So you are saying that for AVN, you would like to directly inject the electronic acid into the AVN, the head, right?
Say again.
What I was saying is, what I was saying is, so you are injecting zoledronic acid into the head directly.
Yes, yes.
That's what.
Zoledronic acid into the head. It's not my idea. It came from the 2 people, David Little and Harry Kim. Harry Kim, I talked to personally. David Little, I just read his work. When they inject the medication into the head directly with the proper technique, it's not just injecting as fast as you can, because people give IV solution through the bone, right? So it can become intravascular very easily. You want to give it very slowly, and they showed that when you inject slowly, the medication distributes in the head, in the cancellous bone, nicely, and stays in there for years. Distributes and stays in there, right? One shot, whenever the blood supply comes back, the medicine is there waiting to inhibit the osteoclast, and blast can take over and decrease the risk of collapse. So this is the least invasive way, or not invasive way, but least intervention I can do to preserve a hip is what we're believing right now. But again, we don't have a series analyzed yet, but we are working on it.
So this is really fantastic. We would like to have you sometime here
Sure.
to see this, how you do that. Thank you, sir.
Can I have one more question? Prasad, intraoperatively, when you do the osteotomies, do you always check for whether the vascularity of the head is maintained by doing a drill hole into the head? That is first thing. And suppose in case there is no vascularity, then what you do then? You leave it like that in that stage, or do you do anything else?
Great question. Thanks for asking. I used to drill every head as soon as you dislocated it, right? Just to see at various stages to see how it's bleeding. Later and later, I became more and more confident. And also, one of the problems of drilling early and keep checking is the hole clots off, and you're like looking at the hole and messing up with the hole again and again, right? So, that I might have something to the like definitely.
Sorry, there is some network issues now.
And these are fantastic things, lots of new things we could learn from.
This is really new. The local injection of
no, the question about what if it doesn't bleed, right?
Sorry, we missed you for some time.
Oh, sorry. Okay, I'll repeat.
Yeah.
Great question about drill hole. Yeah. I'm very particular about drilling the hole to look for vascularity. I used to do it in every hip in the beginning. Every hip, as soon as it dislocates, I'll drill a hole in the front, see if my approach caused anything. And then every step I was doing, I keep on checking that drill hole to look for bleeding, gives you extra confidence. There is a little bit of anxiety involved also.
Yeah.
When the drill hole stops bleeding, you start stopping your operation and putting a little K-wire and messing with it to unclog it and look for bleeding. And at various stages, the bleeding may stop and make you more nervous. So now, with more and more experience, I drill only when I really need to, sort of thing. Like if I messed with a flap, I raised a flap in the back, like a done osteotomy or neck osteotomy, I definitely want to look for bleeding before I close. I'm not doing it right in the beginning. I'm not doing it multiple times in the middle. But once I reduce the head and fix it with provisionally with the pins, then I'll drill a hole, make sure there's no tension. And usually I'm pretty happy with it. So check it whenever you need to. I'm not doing it routinely now unless I'm worried about risk of causing AVN with my operation. Now, the question about what do you do if it doesn't bleed?
Yeah.
Lot of things you can do. First thing is the hole clotted? Is it a proper hole that directed correctly into the epiphysis, into the middle of the epiphysis? Do it anteriorly where you can see it, even when you reduce the hip back into socket. And then decrease the stretch on the flap, lift the knee up, and then it starts bleeding again. If you relax it, you clear the flap again with your finger or the with an artery forceps. You make sure it's not kinking, right? You make sure that it's not stretching. You can even use a Doppler, a sterile Doppler, and follow that flap in the back, and you can see the signal hear the signal really well all the way to the head, right? To look for bleeding. Now, if you didn't disrupt the flap, or you think that whatever caused interruption to the blood supply for sure, right? Then you have two options. One is to wait and get a bone scan. If I think that there's no worries, it just for some reason not bleeding, I have to get a bone scan on the second day. It's more like a vascular study, right? If it's good bone scan on the second day, I'm pretty happy. Nothing to do. If I think that an unstable slip or my operation disrupted the blood supply to the flap, and the drill hole is not bleeding at that point, if I'm certain that I caused AVN, I'll inject bisphosphonates right there and then.
Okay.
To save another to go back again, not to go back again. But if I think that it's a transient ischemia for whatever reason, a little stretch, a little spasm, then warm saline, you can wait, or just wait for a bone scan. And usually it picks up in the bone scan a day or two later. And I have gone back to inject bisphosphonates even 2-3 months after, when I'm concerned. If I have any issues at that point. My goal is to prevent collapse, and the injection is a very simple thing to do, in my opinion, or put oral bisphosphonate for a year.
I see. Okay. Even in children, you give bisphosphonates?
Yes, injection I have no problem, because people are doing it in Perthes children right now. I haven't done it myself, but it's well established. Inject oral or inject. Oral, I'm not sure. Injecting people are doing in Perthes.
Okay.
And oral is also being done. I think why we know that palmitoylate injections have been there for a long time. So it can be done, not oral, but systemic.
And post-operatively, there is a possibility of, because of surgical intervention, the blood supply or the blood vessels, maybe there is some thrombosis causing, again, post-operative occlusion of the blood supply to the head. Is there a possibility, or it's just too theoretical that I am thinking of?
No, definitely there. I've seen it. So here are the situations, right? You can disrupt the blood supply during your approach, right? During your correction, stretch or kinking, or post-operatively, the positioning of the leg, if you didn't align things correctly, and they're way externally rotated, and the flap is being compressed between the neck and the acetabular rim in the back, can cause AVN. If the trochanter is not fixed correctly in a position and it's compressing on the flap in the back, that can cause AVN post-operatively. So that's why my bone scan on second day is my most reliable test. If there's some uptake, it's more like an angiogram study. If the bone scan shows some uptake in the head, epiphysis, on the second day, I haven't seen it collapse. So thrombosis, I have 2 patients, unstable slips. When I dislocated, the head was avascular. But by the time I reduced everything and fixed it and drilled a hole, bleeding pretty nicely. So I restored the blood flow. But post-op 2, the bone scan was cold. So how do you explain something was bleeding intra-op and then post-op? So I actually explored one patient, convinced the family to let me go back, put a Dopplers, can trace the signal all the way till the last 5 millimeters of the retinaculum.
Oh.
It's going to the head. The signal going all the way up, and then it stops at the 5 millimeters, where it was kinked with unstable slip for whatever, 12-14 hours. I unkinked it, but the trauma was enough that it thrombosed again post-operatively, is my theory about it. Right? So I think both those whole bone scans after good bleeding intraoperatively and unstable slips were thrombosis post-operatively.
So such an excellent work, really. Any other questions, CHASANAL or GYAN?
Oh, sir, thank you. Lots much to gain. So we might be trying some, and let's have it sometime after you become president of IU.
Thank you. CHASANAL, anything else?
You're muted.
We're not able to hear you.
Yeah.
Yes, you muted.
No, she has unmuted, but still we are not able to hear.
Might be, sir, the network issue.
Can't hear you, CHASANAL.
Okay. She has given the signal that.
Okay. Thank you. Thank you, CHASANAL. Dr. Prasad, we are really grateful to you for your time today, for at least educating us about the, hip osteotomies, how versatile it is, then how it is really helpful for our patients. And I really liked your last sentence that I, being a hip arthroplasty surgeon, that in any way we are not disturbing the anatomy of the hip, so that hip arthroplasty surgeon not to worry about the distorted anatomy to do a good hip replacement surgery later on.
Yeah.
Thank you very much, and we would like to have more interactions in future in this aspect, and we would like to train more and more Indian orthopods about this hip preservation surgery, which is the need of the day, rather doing more and more hip replacement surgery. Thank you very much. And Dr. CHASANAL RATHOD, thank you very much. In spite of your busy schedule, being there in the Vairak, organizing it, you have been very kind to join us from there and moderating the session. And GYAN, thank you very much from joining from Bihar itself. GYAN is the leader of Young Surgeons Forum of Indian Orthopedic Surgeons. GYAN, I would like to, you to proceed with this, make a group of surgeons who would be trained in the, hip preservation surgery, which is need of the day, and most of.
Yes, I'm about to write about it right now in the group that we had a fantastic session together.
Yeah.
And probably lots of youngsters will get to know much more from you. I'll surely be writing about it.
And I would sure see this video again sometime later again to go in little into the depth of it. Now, Deepak, I hand over to you to give the closing remarks. Thank you very much.
Give me one last word, guys.
Yeah.
So my idea of showing all this is just to show you what's possible, not telling you that you should try them right away. Head reduction osteotomy and arthroscopic neck osteotomy is not for you to do unless you, right? I don't know how good you are yet, but don't make me feel guilty that I've destroyed some hips by talking about it on a forum, please, right? That's a bad thing.
What I always tell to my patient is, if you are able to preserve the God-gifted hip joint, that is nothing better than anything else. One. Second, you are telling about 10 years. I personally, being an arthroplasty surgeon, I would say, even if you are able to preserve your hip for 5 to 6 years also, it's best thing that you can do. So nothing, sir, it's not like that. Everything is preserved by God gifted means it's best. And definitely we need more and more sessions like this for hip preservation for the younger orthopedic surgeons. With this, I would like to come to an end for the season 1 of controversies to consensus in orthopedics, what we need to know. Next session will be a season 2 with a new format with more and more participation from the younger orthopedic surgeons in 2024. The flyer will be released soon from the OrthoTV. Thank you all. Thank you all for the participation, and looking forward to see you in the new year 2024. Thank you.
Thank you.
We thank OrthoTV also for being there and supporting this event. We thank Dr. Ashok, Shyam, Dr. Neeraj, Bijlani, and also Poonam being there in every episode to manage this show. Thank you, Poonam, and have a nice evening.
Thank you, Monty, sir. All your blessings. Thank you so much. Lots.
Thank you. Bye. We can stop recording now.
Sure.
Okay, Dr.